This conference will now be recorded.
You have a lot of experiences in your work. There are things you've seen, there are things you've questioned. So I would really like to have a conversation with you. Behavior change is not written in script. It's not a scripted area of work. Is an area of interrogation, and therefore this morning I'd like us to interrogate what our understanding of behavior is. I want us to see how we interpret the behaviors we see, and I want us to ask ourselves, when we start reporting, whether we are cognizant of what is influencing the behaviors we are seeing. And therefore this morning I would really like us to talk to each other, converse, communicate, ask questions. I will stop my screen sharing at some point to just come back to check in with you and to see whether you have any comments or any questions. So I'm hoping we'll have an interactive session. And at the end of this, we will appreciate why we see the kind of behaviors we see, even despite knowledge. So if it's okay, I will share my screen and I will stop the camera. Was the camera on? I hope yes. But I will share my screen now and start the conversation. Is that okay, Harrison?
Yes, that's fine, Daktari.
Okay. So behavior change, and what is behavior change? Behavior change in the context of public health refers to efforts put in place to change people's personal habits and attitudes to prevent disease. So when we come to issues to do with the NCDs, I'm sure you've already known that there are various risk factors, but the four key risk factors are lack of physical activity, poor diet, harmful use of alcohol, and tobacco use, amongst other issues to do with pollution. So what we would be talking about on NCDs in behavior changes, that these are behaviors that put people at risk of disease. How do we shift behavior change to more protective behaviors towards disease? So that's the challenge we would be addressing, especially in this context. It is also referred to as social and behavior change communication. So if you see somebody says, I'm working on social and behavior change communication, we are still talking about this, and increasingly, and especially in the context of COVID, efforts are focused on reducing exposure to the virus through instilling specific behaviors so that we can save lives and reduce the cost to the health system. So behavior change is basically asking yourself, what behaviors are there? Which of these behaviors are putting people at risk? What can we do to force, to influence, to encourage, to institute behavior change so that people can adopt alternative behaviors that are more protective? I think for me, the challenge has been sometimes we confuse knowledge versus behavior. We basically, and the tobacco industry has shown us how knowledge is not always translated into behavior. The cigarette packaging has all manner of risk factors put on it, has pictures, very, very scary pictures, photographs that would make you think twice before you light a cigarette. But globally, cigarette smoking is still growing. In Kenya, more than 17% of our young people are smoking. So you're basically asking yourself is, what don't we know? This on the right, you see a doctor who who is smoking. What doesn't he know about the impacts of tobacco? What would he need to know to change his behavior? And I think we can stop there for a minute in terms of, we have a lot of knowledge, and for people in the media, I think you are flooded with information. You're flooded with data on the impacts of specific behaviors. But when you look at a population, you keep asking yourself, why don't we know? We know. We are aware. we know the repercussions. But if a doctor can put on a cigarette and smoke, there's even a photo of a friend of mine who's a cardiologist in the US during winter, where cardiologists are outside in the cold after operating, smoking. And as you know, cardiology and smoking are very related. So the question we ask ourselves is, how do we therefore translate knowledge into behavior change? That people know there's COVID, and that 90% of people will get COVID, but people are still not using masks. What do we need to do to ensure that that knowledge translates into behavior that is protective of the population? So, what are some of the behavior change measures that we'll talk about? We talk about effective risk communication that will enable people to protect themselves, their families, and communities from the virus, from disease, from NCDs. This involves providing easy to understand and culturally appropriate information at a community level. Again, if we go back to what has happened in the past, NCDs were considered lifestyle diseases. And I'm sure you've been told about cancer and diabetes and other conditions. And initially we thought, this is the disease of the rich. So me as a woman in the rural areas, I didn't feel myself to be at risk. So my behaviors were not inclined towards protecting myself from NCDs, because NCDs are supposed to be affecting the affluent, the ones who can afford chips on a daily basis, the ones who can afford soda. So sometimes we do need to communicate in a manner that communicates to the people we want this information to reach. Again, borrowing from the issues of COVID, is empowering communities in adopting effective responses and managing the psychosocial impacts of the diseases. Again, the pandemic is there, but if you look at somebody with cancer, how do we respond to it? Do we think if you are told you have cancer, it's a death sentence? And that therefore determines and defines the way the community will approach you as a patient or a household with a patient with that condition. So successful community engagement supported by opportunities for safe communication. I think it's important for us to be thinking clearly in terms of how diseases are defined and what frameworks are there we can look at. I like the social ecological model and corresponding approaches, especially when it comes to behavior change. So, and some of this we begin to say, if smoking is a risk factor, then it's up to Fred to stop smoking. Fred, I don't know whether you smoke, but that's just an example. Fred needs to do something to stop smoking. Okay? So it becomes an individual issue. Yes, it's individual. But the behavior, the socio-ecological model tells us that it goes beyond Fred. It goes through interpersonal relations. Does he have people around him who he smokes with, who even if he tries to stop smoking, they will still encourage him to smoke? That the relationships he has, are there triggers in his environment that make it difficult for him to stop smoking? A lot of us have dealt with people who've gone to a rehab, and immediately they come back, they relapse, because this condition, the context, the interpersonal relations are not supportive of the new behavior that this person would like to adopt. The community, again, social change communication. How is the community mobilized around this issue? How is the community helped to understand about the condition we're talking about? All of a sudden, during this COVID period, NCDs became a key risk factor. We basically thought if you have an NCD, you'll have very severe outcomes and poor outcomes, poor health outcomes. You have more severe disease, and the fatality was higher with somebody with an NCDs, around 50 to 60% globally. And therefore, is the communication to community really supportive of this person? If I have cancer, do I get the community support? Am I accepted? Am I discriminated? Are people embracing this condition? Do they understand the condition? Remember, I said knowledge and behavior are very different, but understanding the condition, knowing that this person at this point in time, because they cannot go to hospital because of the COVID situation, our NCD patients require additional support. So basically the communication around the community that engenders social change, understanding how we engage with communities is very, very critical to managing and to enforcing behavior change. Again, organizational, institutional capacity building through social mobilization. Again, a lot of the questions we ask is, do we have institutions that can provide the care that is required? That even if the community understands, I need to go to a health facility, I need to go to an area, an institution where I can get the support that I need. And therefore, the institutional capacity is very, very important. And at the apex there, you have the policy, advocacy, and enabling environment, that the policy environment is supportive. So if you think through, and I could stop sharing this, if you take one example to take through this from an individual, interpersonal, community, organization, and the policy environment, you can look at a jogger in Nairobi. We tell people be physically active. And we saw a lot of this during the COVID period when people took up to walking. So the individual has made up her mind to start walking. She has friends who she can call on to go and walk with her. That is the interpersonal communication. The community is maybe supportive, but what we saw in a lot of our areas, then we had people now, thugs, wearing jogging clothes and jogging suits and starting to interfere. So the security issues becomes important. Institutionally, are we aligned towards supporting this new habit that people have decided to change their behavior? So they start walking, they start running, but do they even have walkways? So organizationally, the Ministry of Roads, has it taken its responsibility seriously? And then for the policy is also to look at, do we have a policy that is enabling? Do we have an understanding of why physical activity is important? Do we have structures in place to ensure that people take on this behavior? So if you look at behavior change from that element, and you begin to ask questions around the individual behavior, interpersonal behavior, community, organizational, and also the enabling environment, you begin to see a broader picture of how to look at individual activities. So that if you're telling Mary to stop smoking, am I in a context where I can stop? Is there a community around me that is supportive of that? Is there an organization? We have AA for alcohol abuse. We have policy around alcohol advertisement. So we begin to look at behavior change, not from just the individual, although the individual is central, but we look at the other issues around this individual. So if we take this model as an example, it becomes critical for us to interrogate this a little bit more. And we have examples and actions that can be taken to enforce the behavior of our population when it comes to adopting behavior change. Yes, I have the knowledge, but am I living in a context where I can then move this knowledge into practice and it defines the behavior I adopt? I'll stop here and come back to you to just get any ideas from you, any feedback from you in terms of whether this speaks to some of the things you've seen. Anybody wants to say something? I like it when we have an exchange about behavior and knowledge. Anything you've seen? I do not have names. Please, let me go back to names. Anybody wants to share something, please? Hello?
Hello.
Yes,
Hello.
can you? Yes.
My name is Janet Kilalo.
Mm-hmm.
I'm from Lulu FM. So you talked about knowledge versus behavior. And
Mhm.
we have so much knowledge for now because of COVID-19. As media, we've done campaigns, we have given out the knowledge. But then going out into the community, we
Mhm.
see that people are not even wearing the masks. We keep talking about wearing your mask when you go out. But even just by yesterday, when I interacted with some few people, and all they're saying is just COVID is done, as it's no longer there, so people are no longer wearing their masks. So I asked him, where is your mask? He said it is in the pocket. So it seems like the knowledge is there that people know, and the person highlighted that unless it happens to you, then you will know that there is COVID. So for them, it's just information that is out there, but it's as long as it has not hit in the area that they are or a person that they know, then it's just information, but it's not something to follow through. So that is the challenge that we have now, that we have the knowledge, we have given it out, or the information is out, but the community itself, there is not that behavior change, of course, because of maybe even what people are seeing in terms of the leaders, how they are operating right now in terms of COVID, and you're seeing people coming together with no mask. So maybe it's the same thing with those that are receiving this information.
Thank
So the
you, Jane.
behavior change is not there. Yes. Thank you.
Thank you. Anybody else? Example? I think we have a lot of examples from smoking, from eating, from if you're looking at NCD risk factors. Any example? I remember I went to our WHO meeting in South Africa, and for the cocktail there was no alcohol. And as you know, WHO is mainly medical doctors and these big shots, ministers of health. And the complaints give us, we need choice, we need alcohol. We've all talked about harmful use of alcohol. So it's not the knowledge, it is translating that knowledge into behavior. Anybody has seen something that astounds them, that will come back into where we fall short in terms of how we disseminate information, communication, and what needs to be done. Any other example? Any other input into this? Remember, I said I really would like this to be interactive because behavior change is not scripted. It is how we interpret things. Ida, could you say what you want to say, please? I need to hear it. Hello, Munzasi.
Hello.
Yes.
I'm in a public vehicle, so I think you might not hear me well.
Mm. And you're enjoying
Hello?
very good music, yes? Anybody else as I read Ida's message? Please remember, this is supposed to be interactive. That's the way I teach. I do not want to speak to myself. Let me go down. The men are a bit quiet today. Any other input before I go back to sharing my screen? Okay.
Mary,
Hello.
I can.
Yes.
Okay, I think Anne can go and then I'll say something.
Okay.
Hi, Daktari.
Hi.
I think the other problem is the behavior of our leaders. You find them in meetings. There is this Mutahi Kagwe he's telling us what to do to avoid COVID. But when you look at the leaders, what they are doing in their rallies and the meetings, and you see whatever they are doing does not. So you wonder why should I really be bothered if everybody else is not? It's
Okay.
also a problem, and I think it makes our messages ineffective.
Thank you, Anne. Yes. The last one, then I can move.
Well, I wanted to also mention on something that I've noticed about the designated places where people are said they're called smoking zones. I don't know, they have been made to be either not recognizable, or maybe it's a way the government is trying to make them be less within maybe places where people are so many. Because I think of late, the few places that I know, and when you are within Nairobi, I'm making a comment on smoking. It's not because I smoke, but it's something that I have just noticed. So the what I notice is like there is a smoking corner around Jivanji. Then what I noticed the other day is, people are freely interacting. Not everyone is going to that corner. It has just been marked. It's not like a place where people can just get in there and smoke. So at the end of the day, everyone who is around, and when it's a garden, there are so many people. Everyone who is around there, I think, gets to experience what the smokers are experiencing. So when at the point of, I think, policy, like right now we are seeing there are pathways that are being constructed for people to walk in, and I think it trickles down to it trickles down to also such designated places where people smoke and the like. Yeah.
I think for me, I would like us to, and please, participants, I want us to discuss, because it boils down to how we do reporting. So if I think I need to ask you all, for me to walk into this small room that is designated as smokers, what's happening in my mind? Why wouldn't I think in very normal terms? Why wouldn't I ask myself, why are you smoking? Why are you allowing yourself to be discriminated in public? Why are you allowing yourself to be locked up in this small area so that you can smoke with your fellow smokers? I think for me, if you were to think without looking at broadly the policy environment, the organizational, the community, the interpersonal, the individual, we begin to lose sight of what is the motivating factor for people not to take on this appropriate behavior. So I think from a media perspective, when we see people eating junk food, ask yourselves, what is happening? When KFC opened on Ngong Road a few years back, I lived around Riara Road, for those who know Nairobi, and there was traffic jam on Ngong Road up to midnight. Those who know about KFC, is terrible food. From a health perspective, it is one of those poor, bad foods that nobody should be queuing for. Sorry if you are here and you enjoy a chicken thigh from KFC once in a while, but there was traffic jam because KFC had opened. KFC had opened in Nairobi, the first branch, and my children wanted to go there that day. I work on NCDs. I'm an advocate for NCDs. I talk about behavior change. But I'm an individual in a context where the community is embracing this. The organization, the national system has licensed this. The policy environment is not restricting on advertising these foods. So I'm finding myself, even with my knowledge, being subjected to this particular behavior that if the environment was conducive, I wouldn't be affected, I wouldn't be influenced to be part of. So if you think through, that's why I asked you to think through examples, and KFC comes into mind very vividly. I'll give you another example. My son was 2 years, my firstborn, and he told me, Mommy, I want Tusker, my country, my beer. I was with him in a supermarket. And so the question I had was, what do you want? Tusker, my country, my beer. He was 2.5. He was barely eloquent, but he had had it on TV so much, he felt it was something that could be bought. This is individual, community, organizational policy. So that took me directly into the policy environment. Does the policy nurture the behavior we want our people to have? We cannot on one hand be telling people stop smoking, and on the other we are promoting cigarette smoking. We cannot on one hand tell people poor diets, and on the other make it very easy to have access to bad food. So I'm hoping we are together when it comes to how do we influence behavior change. We cannot mandate an individual alone to change their behavior. we need to follow this particular outline, this particular framework. And there are many other frameworks. You have the health belief model frameworks. So there are many other frameworks. But looking at this comprehensively will define how we report on some of these behaviors. So that if we see poor diets as a problem, we need to ask ourselves, why is it a problem? Let's not now start saying, oh, families with money are the ones buying. We've made it easy to access that. If you live in an informal settlement, even for us ourselves, 30 shillings is one apple. 20 shillings is a packet of chips. What would your child buy? Would your child buy an apple or chips? Are we influencing the behavior negatively or positively? So I think those are the questions that I would like us towards the end of this session to discuss. Behavior change depends on several factors that are interrelated and situated at different levels, and I've just shown you those levels. From the individual's cognitive and emotional processes to interactions with family and relatives, broader social influences, and the macro environment. The macro environment is the policy environment, it's the institutional environment, it's the what captures you. We talk about McDonaldization of global health, where what is happening in the West is transferred within hours into Africa, where we are influenced by what we see on Netflix, where we are influenced by what is good living, and therefore our individual cognitive and emotional processes are hugely influenced by those things. People's ability and willingness, as well as the emotional reactions to adopt the proposed healthy and protective behaviors, is a collective interplay of determinants at the various levels. And I guess if I go back to this model, we need to begin to interrogate some of the behaviors, even on NCDs. That I have an NCD, I'm on regular treatment, but because there's COVID, I will not go visit my doctor. What is happening? My family has told me, ukienda utapata, unaweza pata kuambukizwa. The community is fearful of COVID-19. The organization, the health facilities are now focused on COVID, not on NCDs. And the policy environment is mainly, or every day for the beginning, we're only hearing about COVID. It's like all other conditions had disappeared until the acting director general talked about NCDs and told people to continue with their clinics. We saw a real collapse of the care for people with non-communicable diseases. So if we'll go back to this, and I would really like you to begin to interrogate the social ecological model as we discuss this. What has been our experience with communication? And my sister initially talked about how we've communicated. And I'm only using COVID as an example of how, which is very current. Even your own examples were talking about COVID. Fear. COVID-19 is here, and similar to what happened in China and Spain, unless we behave, we shall be in big trouble. Again, we communicate. The way we communicate is very fearful. If you remember, those who were here in the 90s, AIDS kills. And AIDS became really a stigmatized condition because we only looked at the adverse outcome of death. Enforcement. So if you look at how we enforced COVID-19, the militarization of the public health measures. If you don't have a mask, you are beaten. If you don't have a mask, you are thrown in, and there's a hefty fine attached to it. Staying indoors. If you were found outside, you remember that young man who had come from hospital with his child, who was then beaten up because we militarized the enforcement. Many measures were pronounced with little support to households. And some of the people in informal settlements were very clear. You cannot stay indoors without food and other amenities. Again, we need to also realize that behavior cannot occur in a vacuum. That people's behavior around a certain condition needs to occur within an institutional community framework. So if you're telling people to stay at home and you've not taken care of their basic needs, it becomes very difficult for them to stay at home. If you think about Rwanda, what Rwanda did, they identified all the poor, and every 3 days they provided food at their doorstep. So the people didn't need to leave. So they are observing this rule of staying indoors, but they are supported to adhere to the rule. And therefore, that's where the community, the institutional, and the policy environment becomes very important. Trust. Again, the government started by saying we'll have 10,000 cases by April. When this did not happen, there was deep mistrust. But mlisema 10,000, mbona hatujafika 10,000? And therefore, we begin to look at the trust issues. And I think between the citizenry and the government and the media, you know this, we've had a real distrust of the government. And this just deepened that mistrust to the government. Poor management of the patients and the disease. Again, culture is key on all conditions. I'm an anthropologist and I study culture. Culture is key, even on NCDs. Culture is very, very key. I was walking the other day and some Luya guys were talking and they said, Hapana, Papa Shirandula yeye aliwawa. You know, I was like, okay, I passed. I'm a Luya, understood what they were saying, but it's really deep. In Africa, people don't die. People are killed. COVID ilitafutaje yeye ikamuua. So the management of this condition, the way we explain it, and my sister said, we have communicated, but have people listened? Has that knowledge translated into behavior? Has the institution system managed to enhance that behavior? Or has the institution continued to behave normally while they expect us to behave differently? And so in the context of NCDs and COVID and all these conditions, we also need to think about where are these people coming from? What's the cultural basis of how they're behaving? And how can we work around their cultures so that they understand why it's important for them to change? And the examples of COVID have not been very, very, very good. The examples of HIV and AIDS also leave a lot to be desired in terms of how people then eventually begin to look at this condition. So think through this. And when I come back, I need us to think through with examples in terms of how we've talked, but we've not communicated and we've not influenced behavior change. That some of the ways in which we talk may actually be in itself very stigmatizing. And somebody brought up this, do what I say, but not what I do. Behavior is shaped by actions. That behavior change cannot be shaped by you speaking, by Amos talking, by Anne speaking, by Fred, by Catherine Karekezi telling people to avoid diabetes, please exercise, watch your diet. It's by what you do. And in this era, we've seen how we are speaking from one mouth and we are acting on the other mouth. We are preaching water and drinking wine. I think it's been very, very evident. And those pictures I show you there is just some of them. We've had all our leaders not respecting their own directives. We have had our minister, our health officials attending large burials. And therefore, when you ask mwananchi anasema kwani hiyo COVID ni ya sisi. And also even on cancer, we've had our leaders having these conditions, but they do not come up to speak about it. And for the people living with NCDs who are a big key component of the NCD Alliance, speaking about it, providing leadership, is influencing the community around you to take the necessary action. So you see things like this and you ask yourself, what is happening in this country? Corruption, the expose by Okari created doubt and intensified the lack of trust in the government. And a lot of people say, kama mnaweza kula pesa ya wagonjwa, how can we trust this government? So again, there's a big issue around trust and how we communicate and who is communicating. So if somebody was asking, how do I explain cancer to my mother in a language that they understand? How do I explain dementia in to my mother and they understand? In NCDs, we also deal with mental illness. How do you explain depression to your family and your grandmother understands what depression is? And in a lot of African languages, we don't have a word for depression. The way Mzungus understand depression, we do not have it. We understand it as deep sadness, very, very worried, but not depression. So any illness around the mind, we call it madness. How do we communicate about it? Who is communicating about it? How do we trust the communicator? And that's why the people living in the NCDs become a key conduit of information to our communities, because they've lived the experience and they are able to articulate their feelings, their experiences to people in a manner that some of us cannot communicate. And for COVID, again, because this is very current, the way we communicated was very central, was having a national communication every day, and there was no information reaching the local people in a language, in a manner that they would understand. So again, let us think through the communication and the communicator. There's a lot of stigma on a lot of conditions, and the stigma on mental illness, all of a sudden, if you had an NCD, you became a discussion point in terms of COVID. You became like, well, kama kuna diabetes, ukipatikana na huu ugonjwa, you'll be at a worse state. So again, we build stigma because of the fear, because we do not know how to address the condition, because we do not understand what is happening. There's no remedy for this condition. So we stigmatize it. And the fear around conditions becomes a real Achilles in the way we manage them. Therefore, for COVID, I think we've talked about that. But from media, I think one of the key challenges has been how we communicate, the words we use that really, really matter. And I'll just give you an example from COVID-19, and that can be applied to cancer patients, diabetes patients, mental illness, all these conditions that are chronic, that we barely understand and that we do not have any strategies to address. For COVID, what we've told people, don't talk about people who may have COVID-19 or people who are presumptive for COVID-19. Don't talk about COVID-19 suspected cases, COVID-19 victim. And we've used such words that have not engendered support to the people with COVID and these conditions. We also can do this. Oh, that one is a madman if somebody has mental illness. The people who have this condition have these characteristics. So we begin to characterize the patients in a manner that, through the way we communicate, through the way we write, that is not very supportive of them. For people who've died, we talk about the deceased or the person who is dead, but don't talk about the body, the cadaver, the remains. And I think I've talked about this, I've written about this, where we talk about the remains of this person, the victim that died, the body will be disposed. I mean, before we pen things down, before we pronounce them, just remember the body is of a person, the body is of a father, the body is of a daughter, a sister, a wife, a mother, a grandmother. And therefore, the way we talk about this is in itself can deter behavior change, that we are communicating, but we are communicating wrongly. Again, the disposal of the body is something that we talked about. Talk positively and emphasize the effectiveness of prevention and treatment measures. For most people, this is a disease they can overcome. For most people, even with cancer, is a condition they can live quality life with for a long time. But the way we approach it is like, if you have cancer of the breast, utatolewa matiti. If you have this, if you have that. So we basically look at the more severe outcomes rather than emphasizing the fact that you can live a quality life, you can live well. And the way sometimes we report, again, does not foster the community responsibility, the communal engagement. We don't look at the policy environment, the social safeguards that we may need to build around people with these conditions to enforce behavior change. Because remember, the social ecological model has shown us that as an individual, you may be very committed, but the people around you, the community, the institutional framework, the policy framework, have a bearing on the behaviors we adopt as individuals. Okay, so it's don't dwell on the negative. Don't dwell on what would happen if somebody didn't take this behavior. We need to look at it wholesomely. We need to communicate in a manner that fosters the adopting behavior change that is protective of the individuals. If we are talking about the risk factors, we do need to look at the practicality of enforcing a positive behavior change. If you want people to take up physical activity in school, kids to take up physical activity in school, you've got to talk about the school curriculum, the calendar, the facilities. We've got to look at what enabling environment is there that can then help the adoption of that behavior that we are desirous of. So I think we need to begin to interrogate that a little bit more critically in terms of this is what is required. What do we need to shift that behavior? If we want people to eat consume healthy foods, what do we need to do about the sugar tax? What do we need to do about advertising fast food to children? What do we need to do about making fruits and vegetables more accessible than crisps and other foods that have been shown to increase obesity in children? If we are talking about access to healthcare, that this is a cancer patient already, do they have access to radiotherapy? Where do they need to go? Because it doesn't make sense for you to tell somebody in Lokichar to travel to Nairobi to access medical care. So basically, as we interrogate these conditions, as we begin to talk about communicating behavior change, we also need to look at the environment around these people. Again, we have the behavior we've talked about, the behavior we expect, and the behavior we want to see. This woman in this photograph, this is a mural in a community here in Nairobi. And this lady is wearing a mask, but there's a problem. Her mask is under her nose. She's doing the right thing, but the wrong way. So in as much as we've communicated, we've talked to people about behavior change, it is important for us to ensure that they understand why they are being asked to do whatever they're being asked to do. We sit in a matatu, we put on the mask. When we see the policeman, we put it up. When the policeman passes, we put it down. Are we doing it for the policeman? Are we doing it because we understand it's a protective behavior? And for us to enforce protective behavior, we need to look at the whole ecosystem around enforcing that behavior, not in a punitive way, but in a supportive way. Friends and family, if I'm with my friends and I tell them, if you don't wear a mask, this trip is not happening. So they will begin to feel we are supporting each other, the community around is supporting each other. If you go to some communities in Western Kenya, you are asked if you are wearing a mask, kwani wewe umetuletea corona? Because if you are wearing a mask, there's something you are protecting them from. So a lot of us, when we reach there, we remove our mask, we put it in our handbag, na tunakuwa Wakenya kamili. So it's important for us to think about the ecological, the ecosystem around that is supposed to be engendering the behavior we think is protective. And I think as I finish this, for people in the media, for us who report on this, it's very important for us to begin to question the system around the people we expect to change. The understanding that this behavior cannot be fostered by the individual, that this behavior can only be fostered if we all pull together and ensure that the conditions are conducive for this person to observe the desired behavior. And for NCDs, I think we've talked. I'm chair the advocacy team for the NCD ICC Intersectoral Coordination Committee of the Ministry of Health, and we are grappling with how we address difficult issues such as sugar tax. South Africa did it, and it was an expensive process, but they eventually did it. So is that a possibility that in this country we can begin to talk about sugar tax? Because we can talk as much as we want to talk, but unless we begin to build a policy environment that is protective of our communities, that people, when they say, I will not take sugar, we are supporting that behavior of this person. We shall be talking to ourselves. We've been talking about issues to do with advertisements of alcohol. We see adverts all the time. Although there's legislation around advertisement, it's very difficult for you to ring fence your children, ring fence your family from all these adverts. If you have soccer fans, Guinness Black is something that I'm also curious about. Why is it called Guinness Black? But if you every day you are confronted with that, every break you have Guinness Black in your face, how would we expect that our young people will not get curious? Because part of growth is curiosity. Are we enhancing that behavior change? On one hand, we are telling young people do not drink. On the other hand, as a community, we bombarded them with enticements towards adopting that behavior. The third one is around physical activity. Again, our roads are not convenient for us to engage in physical activity. So unless we address the institutional issues around ensuring that this behavior then becomes an adopted and sustained behavior, we begin to talk to ourselves. When it comes to issues to do with pollution, our industries are polluting. And if I live in Mukuru, I live in Viwandani, and we are talking about exposure to environmental smoke and environmental pollutants. Unless the government itself begins to look at that as an issue, we can begin to talk about respiratory conditions for a long time. And that behavior needs to start from a policy environment. So my colleagues, I think when we begin to tackle NCDs, we do need to look at that as a broader issue that goes beyond an individual. And as we interrogate access to treatment, behavior change, why people are not adopting behavior change, we do need to look around to see whether the ecological system around them is supportive of that behavior. So I will finish there. And I can come back to some of my concluding remarks, but I'd like to open it up for conversation, discussions, questions, comments from the participants. Over to you. Thank you.
Thank you so much, Mary, for that very comprehensive presentation. So I think as you've said, let me pick some comments here from the chat box as maybe people prepare also to share. Caroline Katana says, thank you, Daktari, for this informative presentation. In Kwale here, we have a challenge of drugs that has changed the behavior of youth. I think if the government can stand up and say no to drugs and proper action taken against drug traffickers, I think our communities would be addicts free. But unfortunately, the people we depend on are the ones encouraging it for their own benefits. This becomes a challenge when it comes to reporting, surely. Yeah, so I think that's a comment from Caroline from Kwale, and I can actually relate to this because I am in Malindi, and surprisingly, I'm working just next to the Malindi District Hospital, and every day I see groups of drug users coming into the hospital. There's something that they are being given so that it can help them not to continue the behavior, but they take that, and just outside the fence, the drugs are being sold and everything is just happening as normal. So I don't know if you have a comment on that, Mary, but it's really one of the things that I think down at the coast we are struggling with. The drugs, it's been something that has been mentioned over and over again. Once in a while, there's police coming and taking guys out, and then it's all forgotten and people are back to their normal behavior.
Okay, I'll come to that. I need to hear from members a bit. And Mikia says, what would you say about young people whose dads are alcoholics? There's a lot we can say about that. Can I hear the ones who want to speak, and then I can come to the written comments later? I really would like to hear you guys. These are our people. This is our community. Is there a function for raising hand on this thing, Harrison? Okay,
Yes, there
anybody
is.
wants to say something? Please raise your hand. I would like to hear from you.
Hello.
Yes.
Yes, my name is Michael Otieno from Msenango FM. And I want to thank you very much, Dr. for that presentation. And you've talked about maybe the language that we use, especially in radio, as we report. And especially, I saw this vividly during the coronavirus pandemic. You find that sometimes we do sensitization and people ignore the information that we give them. For example, people are told don't gather, don't attend maybe political gatherings, don't eat in the funerals, but you find that they ignore. So it reaches a point. I can give an example. You want a child, don't eat sugar, don't eat sugar, and the child continues doing so. What you do the following day, at least you take a whip and whip the child so that he will be able to identify that when I continue eating sugar, there will be some punishment. So you find that we try to sensitize, but they were not taking precautions. So it reached a time you are telling people that when you go to that meeting, this will happen. And again, people were thinking that maybe there are people who come from hotspots are the ones that can be infected with the disease, especially Mombasa and Nairobi. So we found that people maybe from Kwale, from Kilifi, they found that life is just normal. So it reached a point where sometimes we were forced to give an example of a person who has been infected in the nearby, so that they get to know that at least this thing is here with us. So sometimes it is just an emphasis, not a threat, but we just emphasize so that they get to know that indeed this thing is real. But that is now the last resort when we try to give to sensitize, but they do not take precautions. I don't know whether that is wrong or I don't know what you can say about it, Doctor.
Okay, so we'll come back to that. I think the key challenge is always the self-actualization. Do I think I am at risk? And at some point, a lot of people thought they were at risk. But if you ask that question today, a lot more people don't think they're at risk. So if you feel you're at risk, as a community, as an individual, you take specific actions. But if you feel the risk is remote, and initially, if you think about even cancer, even let's just go back to diabetes, unless you have a test and your sugar level is high, a lot of us always think, mimi haitanishika sikunywe sukari. So we have all these assumptions and misconceptions about these conditions that we do not think we are at risk. Until somebody very close to you or your mother is diagnosed with diabetes, and then you say, I could be at risk. I live with this woman, I've eaten the same food, she's at risk. So unless we actualize the disease, but you see the problem you've done, sometimes you do is we threaten them. Musipofanya hivi mutakuwa na ugonjwa kama fulani. And we know in behavior change, threats have not been very, very successful, and you can talk about that. I think I've seen several comments about drug abuse. Drug abuse capitalizes on addiction. And every effort by any drug peddler is to hook a young person to drugs. Once you hook them, once they are addicted, then you have a sustained flow of income. So for you to be successful is to break both, break the hooking and break the supply. The supply side can become very antagonistic, and somebody has said that it becomes very difficult to report because of the need for them to sustain their income stream. And in terms of the coastal region, I think have done some work on this in the past. It's a very, very difficult thing to break. Because one, you've hooked these children, you've hooked these young people, and you have a supplier here who requires that constant supply. So they'll do anything to ensure that these people continue to be hooked and they recruit other people. And that cycle needs to be broken. And for you to break it, you cannot break that behavior through threats. You really do need to have a more concerted effort from a household level, from the community level, the religious side, the judiciary side, to work together. You remember, if you go back to the socio-ecological model, this is the individual, this is the household, this is the community, the institutions, and the policy environment. So unless all those groups work together in tandem, we'll continue to have this challenge, especially among our youth. And there's always an effort to recruit more. There's always an effort to bring more into the web. So, and that will continue unless all of us begin to say, this is a problem. It affects individuals, but these individuals live within a household. The household lives within a community. We do need to have concerted effort around that. I saw another question, and I really would like to hear from people. Somebody said, when creating awareness, say Breast Cancer Awareness Month, is behavior change one of the objectives as to why these days are in the health calendars? I think the biggest push to have these days has been to raise awareness. The need to ensure that people understand. The need to talk about it. Remember, cancer for a while was a very silent condition. People talked about cancer in hushed voices. And therefore, through cancer advocacy, these days were put out there to ensure that people know about cancer. Not only knowledge, these days are often accompanied by activities around cancer screening, care, cancer information, cancer walks. So there's a lot more activity around it. But most importantly, is there's a service around it. So within this month, you will have cancer screening services, you'll have cancer day, cancer clinics happening, so that people have an opportunity to focus on this as an issue. A lot of us don't even know how to self-examine for breast cancer. You are also taught how to self-examine. We are also given information on how to care for somebody with cancer. My colleague, Dr. Zipporah Ali, will be talking about palliative care for children with cancer, for women with cancer. And so therefore, it's just not a day. It's a whole event around enforcing behavior that is protective or preventive of cancer, but also protective of people who already have cancer. So if you take those days, there's a sickle cell day, there's a prostate cancer day, there's a cancer day, broad cancer day. So there are all these days that are celebrated globally to increase awareness, to enforce behavior change. A lot of us don't screen. unless we feel we have a problem. So these days provide a way in which we can change our behavior as Africans. We only go to hospital when we have a pain. We are saying don't wait for the pain to come. This Cancer Day allows you to go to have a mammogram done if you need one. It allows you to be taught how to self-assess for cancer. It allows, if you have cancer, to go and access services. So that's why it is important for us to take advantage of these days. There's somebody who talked about the language is disabling. Yes, it is. And I remember one of our NCD partners doing a whole blog on terms of don't stigmatize diabetes because of COVID. Because now anybody with diabetic, they felt they were vulnerable. Remember, it starts from the individual, the household, the family. And therefore, when we start saying, ukiwa na diabetes, ukipata huu ugonjwa, death, the proportion of people who are dying are this from this condition. So you basically begin to affect the individual patient, the caregivers, the facilities, that if you have cancer, if you go to hospital, then they may not look at you as a priority for care because anyway, you are a person living with NCDs. So the way we report, the way we approach these conditions is very critical for us to think through the implications. Again, media is part of that social ecological system. The media is a very influential part of it. And therefore, if this begins, we do need to caution that doing this may exacerbate or may influence adoption of negative behaviors in the process. Okay. Well, somebody has asked, Anne, what would you say about young people whose dads are alcoholics and who almost miss education, but when the moms struggle to educate the children, they get jobs and they take up the dad's drinking behavior, even though they are aware of his effects? Again, we had a speaker not too long ago who was talking about alcohol, who was talking about the influences. Almost 39% of young people who start drinking start at home. Either the bottle tops, the little things that remain at the bottom of the bottle, or the whiskey that remains if you are drinking at night and you are not very sure whiskey ilifika wapi, atakuja toe kidogo ama ongeze kamaji kidogo. So a lot of 39%, around 39%, I can check for you the figures, don't quote those, I can check those for you. But this lady talked about a lot of young people who start drinking start at home. There's also around 40%, according to, and I can give you a contact, you can have a conversation with her. She's called Esther Olo. A lot of the young people who, there are some families, some genes, that if you start drinking, you take one, you will take another one and another one and another one. Some of us may never take. We may take the first test and we don't like it and we stop. Some of us will be responsible, we'll say we are taking two, we take two, we go home. But some of us in our population, once you take one, you are gone. And so it's important to think about families, if you have alcohol at home, how to support your children not to take alcohol. We have children as young as 10 years in rehabs. We have children as young as 8 years struggling with alcohol and drug addiction. And if you trace it back, a big proportion of it started from the household. So again, it's very important. And mothers struggle, but if the young people start drinking, it becomes a cycle of drinking and drinking and drinking. So it's important for you to also think through this as we talk to households, as we talk to families. The exposure at home could be have long-lasting negative effects on the young people. Again, there are people who are very good in this area that I could draw your attention to. I think the issue of drugs we've discussed. How awareness is done in this country depends on who is or has been affected. It's therefore sends a wrong message and makes it difficult to change a certain mindset in community. Again, I think it's important for us to recognize that we are part of the community as the media. And sometimes, again, the way we report, we may focus on specific individuals, but we are part of the ecosystem. So if we understand that it's not about the individual, we can have influencers, which is important. And I think we need to acknowledge that if an MCA in a community is influential and they talk about something, it will be heard. So we may approach that MCA to be our spokesperson. It may be a women's leader. It may be a personality. It may be somebody who is well known. So we look for champions. We may look for Eliud to talk about physical activity, because if Eliud talks about it, people will listen. So the conduit of information is important, but the language in which it's communicated and the way in which it's communicated and where it is communicated are also important considerations to make. So and that has been the challenge, especially with NCDs. We've not really had a good spokesperson. We keep saying that if you look at parliamentarians, maybe a very big proportion of them have hypertension, but they'll never speak about their hypertension. A big proportion of them have diabetes. They'll never speak about diabetes. Will we listen to them? I don't know. Will it make a difference if they talked about it? Maybe it would make a difference because they are policymakers. So we do need to engender this accountability, mutual accountability, that I'm accountable for my community. I'm also accountable to the people I live with and to the society. Another question here is by Michael. The freedom of media has been completely infringed on because of the situation or company policies. For example, a shop that sells junk food advertises the same in the radio station. So again, telling the listeners to avoid such good becomes a challenge. I think that's why we talk about a policy. If, for instance, the government was very clear on advertising junk food, advertising alcohol, advertising sugary foods, even the media houses would have to adhere to it. But if we are not enforcing, and I come to Nation Media or to Inoro and I say, I would like you to advertise this restaurant that has opened or this shop that has opened, this is what we are selling. You have no legal basis to refuse unless you are very moral. But also there's competition for resources. So this is where the policy institutional environment becomes very critical in enforcement. That we are still advertising sugary foods in an environment where we know sugar is bad for you. But we cannot not advertise because Coca-Cola has paid premium for this advertisement. Our hands are really tied, especially in the media, because there's no policy direction about this. So that is very understandable. And we need to advocate for other areas of activities around that. Somebody has said this is good information. I must say that ever since we started this teaching, I stopped taking sugar and now I exercise every day. Again, I think the whole issue of leading from the front is very important for us as people. And media people, you are influencers. And that's why NCD Alliance has decided to spend time to have a conversation with you. Not only what you say when you write or when you're on radio, it's also what we do. You remember we said about politicians and what we do? Actions are better influencers of behavior than even what we talk about. So if you adopt an important behavior change, you may never know how many people you are influencing through that adoption of that behavior change. So as media personalities, as people in the media, your behavior is a key influencer to the way we act, to the way we behave. So it's important for you, and I'm happy you're learning about some of these things. It's important for you to adopt, change, and influence people within your cycle. And you never know the ripple effect of that influence. It may go further than we think about. Sometimes if the information is sponsored by so and so might deter the behavioral change that we need to see. So I think through this education series, I'm hoping all of you represented here, you're beginning to question some of the things that go on in your areas of work. That is the hope we have, that you become ambassadors of NCDs. That if somebody wants to advertise something, you become sometimes the voice of reason. That isn't this a destructive advertisement? Isn't this a destructive conversation? So that in your media houses, in your separate places, you become the voice of reason. If you see a group of people being blamed for a specific behavior, you can sit back and say, but by the way, why do we have alcohol kiosks around schools? That's one challenge we have. Why do we have establishments selling junk food in schools? That's another challenge. We can begin to question that so that we are not blaming the young people who consume these things. We are also looking at the environment around the young people that makes it difficult for them to adopt a positive behavior change. You have children, some of you. You go to school, you will find outside a school, there's a lot of crisps na vitu zingine. And on this side, you have apples and bananas. One banana is 10 shillings. Crisps, a small pack is maybe 5 or 10 shillings. And the young people will tend to gravitate towards the cheaper and more filling, worse alternatives to nutrition. So it's important for us to begin to interrogate that in a very creative manner, that you are not challenging the status quo, but you are just making sure your colleagues understand that you are actually fueling a negative behavior. Okay? Can we also say NCDs has contributed to GBVs in this country? I'm not so sure. Caroline, can you explain that a bit? Are you here? Caroline? I do not understand your question. Hello? I can't hear Caroline. Can we say NCDs has contributed to GBV in this country? Okay, so I will just ask myself, do we see GBV in context of NCDs? And I will say yes, we see cases of GBV in the context of NCDs. For instance, if a woman is diagnosed with breast cancer and people feel desperate, they don't know what to do. Some women have been abandoned because of these cancers. Some women have been abandoned because they have cervical cancer, or there's abuse at home because of the condition of this person. So I do not know whether that's the question you are asking, but what we've seen that in the context of some NCDs, there have been negative gender relations around that condition. You have all of a sudden you develop cervical cancer, you develop prostate cancer, and GBV can be emotional or physical, and therefore we see a lot of emotional abuse, lack of support, neglect in the context of NCDs. And that's why we were talking to Zipporah earlier, and she's talking about palliative care, mending relationships between households when they are faced with this condition that they cannot deal with, they do not understand, that is staring at them on a daily basis. It can definitely lead to gender-based violence, gender-based problems at home in the context of lack of alternatives and the difficulties brought about by chronic conditions. And so it's very difficult. Somebody saying, I think being in a developing country is hard. The economy is not friendly. Like in town, fries are 100 shillings, and a place like brunch, a healthy meal is 600. How can you convince people to change their lifestyles in consideration to their pockets? Again, of choices is something that we need to worry about. that you can make a meal at home if you are able to, and carry to work, those who can. And thinking about the consequences of that behavior. We talked about behavior change being within a framework that if I continue in this lifestyle, it may be cheaper for now, it will be expensive for later. And that is the communication we need to be giving. That is the communication today we need to be investing in. That if you are not physically active, that if you are consuming unhealthy food, you may not see the implications today. The implications may be 5 years down the line. So that we are influencing behavior now rather than waiting for behavior change when you are already sick, when you're already having the consequences. For NCDs, I prefer working with young people in schools because if you can influence the thinking of young people, if you can influence their approach to food when they are still 10, 12 years, I have a better chance of reducing the impacts of NCDs in their life cycle than if I start with a 50-year-old who has adopted these negative behaviors, who is already having some of these consequences. So the communication we are giving today to our young people. And that's why I have a problem with advertisements for alcohol. I have a problem with advertisement for food. We are not building a community that is resilient. Just think about it. COVID has not played out the way it was expected to play out globally. Is it because of our nutrition? If COVID were to come 10 years from now, how would our children fare? How would our children fare if it came 10 years from now? A lot of us were brought eating all these foods. We didn't have access to all this fast food. 10 years from now, if COVID came, just think about it. What would the outcomes be? Would it be the same? Would Africa fare better than it was expected to fare globally? Would people in the globe say, Africa again has defeated them, has gone against the grain? Or would we be the same? We need to lay the foundation today. We need to talk to children. We need to enforce some of this legislation we have. We need to have sugar tax. If you guys will help us on this, we need to stop alcohol advertisement. We have a population that we need to begin to protect for the future. We were protected. We cannot leave this population vulnerable. Somebody talked about, I think we talk about sugar and its connection with diseases. It doesn't just refer to the sugar we add to sugar only, but even carbohydrates in excess are converted into sugar. I've seen diabetes patients to ensure they reduce their carbs intake and increase vegetables. A balanced diet though, but be careful with the carbohydrates. I agree. Be careful with the carbohydrates. But also remember, the sugars we are really concerned about are the imported added sugars that are advertised. Remember, we're talking about behavior change communication, what we tell people. I think it's very critical for us to go back to traditional eating, to increase our intake of traditional foods and vegetables, but also from a policy perspective to curtail the advertisement of this fast food that have added sugar and added preservatives. Sugar that we add to tea, I meant. Okay, sour. So I think as we go along, just to finalize, to make my final remarks, how we communicate is important. How we contextualize our communication is very key. How we look at the different levels of responsibility and accountability is very, very important. The accountability is at an individual level, but it flows all the way to you as the friends, to the household, to the communities, to the society, and to the government and the policymakers. So the levels of accountability are multi-layered, and we do need to think about that as we look at NCDs, as we look at COVID, as we look at all these conditions that continue to impact very negatively on the lives of Kenyans. So I hope behavior change is not instantaneous. Behavior change is not just an individual decision. It depends on what else is happening around this. From an NCD perspective, I would really like you to look at the risk factors and look at the level of influence through the socio-ecological model, so that as we talk about prevention of NCDs, we are aware that the influences are many, the actors are many, and the need for all the actors to come together to coherently address NCDs. Okay? And the change starts with you. Thank you very much, Michael, and your actions as an influencer. All of you 50 who are here are influencers. The way you speak to people out there, the way you behave, what you do may have better impacts than what you say. So let's talk, walk the talk, and let's influence others that way. Back to you, Harrison. I am done unless there's a question or a comment from the participants. Back to you, Harrison. Thank you.
Thank you, Dr. Thank you so much for that comprehensive discussion of behavior change. I believe everyone here would agree with me that this was a very insightful session, especially with regards to how we can influence behavior for realization of the change that we strive to achieve. Yeah, so I would just want to say thank you, but before maybe we close, I'll first invite Fred to give us a brief of the plans that we have for the media. And as you do that, I know the number of feedback coming in to you in the comment section. You can keep on checking them. So Fred, maybe you can give us a brief of what we plan to do. You know, it's Breast Cancer Awareness Month, and the next session, which is on Wednesday, and then probably I'll hand it over to Dr. Karekezi to say a few remarks before we close. Thank you.
Thank you so much, Harrison. And thank you, Mary, for the presentation. So a few things to take note for fellow journalists. This month, as I had indicated earlier, it's Breast Cancer Awareness Month. And some of us had already shared their program on exactly when they would wish to have interviews. And I have put that also together and shared with Harrison. So what I'm looking forward to is as your day approaches, on the exact date that you wanted maybe to do an interview with a specialist or a patient, then you will just help me get to share the names early enough. And what I'm requesting is sometimes you might not be able to keep track when you have either made a news mention or you've done a feature. So I'd always appreciate if you can share the link or a record of what has gone on air. On 10th of October, there's also, it will be, we'll be marking the Mental Health Day. And also, I think we can take that as an advantage to also, highlight some of the events that will be happening. Charity Muturi was one of our presenters some time back when we started the training, and she mentioned that they will be having a press conference release, I think tomorrow. So once that is out, I should be able to share as well as maybe a record of what would have been said then. But moving forward, I think we are closing into the second week of October, and I think we can pick up as many interviews as possible, especially when it comes to breast cancer awareness. We have people who are ready to share anytime when called upon, whether it's a phone interview or if you need them to either physically come to the studios, I think they will be ready to share. Both in English and Swahili, we have people who are ready for that. And at some point, we were thinking, even if you want somebody to maybe be interviewed in a local language, we should be able also to link you with such. Otherwise, thank you so much. There's also a lot of information on our social media pages and NCDAC. I want to urge each one of us to always be checking out on that page on Twitter and Facebook for more of the information that is being posted, especially for this Breast Cancer Awareness Month. There have been updates like every other day, and I think that information is key to just help you catch up with what is happening now. Otherwise, thank you so much for your continued support in highlighting some of the cases around NCDs. Harrison.
Thank you, Frederick. And maybe also just to add that our next week's session will be on Wednesday at 11. So maybe we can plan with that. And then now just to probably invite Dr. Karekezi to close for us the session. Dr. over to you.
Hi, good morning, everyone, and thank you very much for joining us today. I trust you can hear me. Harrison?
Yes, we can.
Okay.
We can.
Okay, thank you. On behalf of NCD Alliance, I really want to thank Dr. Mary Nyamongo. I know she's one of our board members, but I just want to say thank you very much for a very informative and a challenging discussion this morning. The fact that we think that behavior change is an individual responsibility, but she has reminded us that behavior change does not happen in a vacuum, and that we all have a role to play, and everything needs to be synchronized in order for this behavior change to take place. So thank you very much, Dr. Nyamongo, and we look forward to continued engagement on other areas, and I think we'll pick you up on we'll contact you in regards to the aspects of alcohol and other issues that you mentioned, which may be of interest to the media community. Lastly, on behalf of NCD Alliance, I'd just like to thank each of you for joining us today and for your continued support, even as we have continued to create awareness about NCDs in our communities through the work that you do. And we ask that you continue to really just make the changes that you need to your life and also to influence those with whom you interact. So I just like to say thank you very much, and we look forward to meeting you again on Wednesday. Next week on Wednesday, we'll have Dr. Eva Jenga, who's the chair of NCD Alliance, who will be talking to us about NCDs and infectious diseases and what is the interaction between the two. So we look forward to hosting you again on Wednesday. It will be at 11 o'clock, not at 10 o'clock. And this is to accommodate Dr. Jenga's schedule. So otherwise, have a good weekend, and we look forward to meeting again next week. And yeah, keep safe and keep well. Thank you very much.
Thank you so much, Dr. Thank you, everyone. Have a wonderful
Thank you,
weekend.
everyone. Thank you. Have a good weekend.
Bye. Yeah. Bye, everyone. Thank you, Mary.
Thank you.
Thank you. Bye.
Thank you. Bye.
Bye.